Now it's our pleasure to have Dr. Fairooz. She will be speaking today on entropion and ectropion. Evisceration and enucleation. Yeah, I correct myself on it. Dr. Fairooz represents us on the in the scientific committee of AIOS. She is the member scientific committee. She is based in Bangalore, and also she is an international oculoplastic surgeon. She goes regularly to Dubai, I think, Dr. Fairooz? Yes. Dubai, I think twice a month, and she does surgeries there also. She is in a significant demand all over.
Yeah, Dr. Mukesh is very, very kind. Very kind for the introduction, and also very kind of you to have me in this course. So, well, as Dr. Grover said, this course has been running for many, many years. And how is it very popular is because we talk about very basic things for the general ophthalmologist and what you do in your practice, and it also suits for the specialist with, intermediate, making it an intermediate course of giving information. And what I like about this course is it's mainly surgical. So what Dr. Mukesh has given me the responsibility today is one of the most easiest oculoplastic procedure. And well, let me take a show of hands. How many of you do evisceration and enucleation in your practice? Well, how many of you do blepharoplasties? Okay. All right. So yes, the show of hands is the same. Right. So, right. This is my affiliation and few of that which has been mentioned by Dr. Mukesh, my financial disclosures. Now, Dr. Ashok Grover has already showed you regarding the contracted socket. So I am actually a line before the contracted socket, This is how you avoid a contracted socket and the aftermath of the cosmetic blemish that you create in a patient. Now, losing an eye and sight itself it's a huge trauma for a patient. So it is our responsibility, not just as an oculoplastic surgeon, even a general ophthalmologist, to get to see these patients regularly in your practice to give them volume replacement. No evisceration, no enucleation should be done without an implant. Although the patient might look good with the prosthesis initially, but in due course of time, at some point, they're going to land up with a contracted socket. Now, so losing an eye, and this is how, we finally land up with a near-natural cosmesis. Near-natural cosmesis is with a good surface and also a volume. This is a retinoblastoma child. You can hardly barely make out that the child has lost his left eye. Well, simple, straightforward. I'll keep it completely video-based here. We all know the indication of enucleation, intraocular tumors. A, intraocular tumors, B, intraocular tumors, C. So whenever there is no evidence or a history which indicates to a trauma or anything which is going wrong in a painful blind eye, you should always ensure that there is no tumor lurking inside that eyeball before you do an evisceration. If it's doubtful, enucleation is the treatment of choice. And of course, phthisis bulbi, which is very, very severe, and then trauma with a severe globe rupture where you cannot actually salvage the sclera, then you go for an enucleation and microphthalmia. The principles of surgery is very, very direct, straightforward: meticulous dissection, volume restoration, muscle attachment for the motility, and 3-layered closure to avoid exposure and extrusion of the implant, whichever implant that you have kept inside, and obviously a customized ocular prosthesis. I'm just going to take you through this video of enucleation. This is what I do regularly in my practice. It is the minimal manipulation myoconjunctival technique. This is a case of retinoblastoma. So especially in intraocular tumors, it's very, very important to do an indirect ophthalmoscope and make sure that you as a surgeon mark the eye, which eye you're going to enucleate, especially when a child is with bilateral retinoblastoma. So this is a 360-degree conjunctival peritomy, which is very, very neatly, nicely done. Salvaging the conjunctiva is important because that is ultimately going to be your surface So save it as much as possible. This is the tenons which is getting separated with a tenotomy, blunt tip scissors, all the 4 quadrants in between the muscles, and then you identify the muscle. This is a simple muscle hook, that is the medial rectus. Be very gentle with these tissues. This is a traction suture which I 100% use in retinoblastoma and intraocular tumors because that gives me a traction. I'll show you that step later. And this is the tack suture of the muscle. So we go step by step. Now this is the inferior rectus, then we go for the lateral rectus, and then we go for the superior rectus. That's a superior oblique where we don't tag it, but we just cut it. Similar way, this is the inferior oblique, we don't tag it, but we just cut it. It's a very thick muscular vascular muscle, so we often use cautery to do it. Now this is where the traction suture helps me. There's a small conjunctival opening in a small baby socket. This traction with the black silk gives me a long optic nerve stump, and that is my aim in enucleation in a case with retinoblastoma. I need a long optic nerve over here. I target for at least 15 millimeters, so the traction helps me. Then I cut the optic nerve. In fact, if there is any scleral thinning, you mark it and then you send it to the pathologist. So well, that is what how the removal of the globe is. Formalin, I'm not going into it. So this is a PMMA implant which is kept posterior to the posterior tenons. And then this is the posterior tenons that I'm closing here, the posterior fascia. And then the muscles are attached to the respective fornices, medial to the medial fornix, inferior to the inferior, lateral to the lateral, and superior to the superior fornix. And after attaching all the muscles, that's the inferior, you take a thick bite, juicy bite of the anterior tenons, and the anterior tenons is closed, and after the anterior tenons is closed, the conjunctiva is closed with a continuous buried suture. So that is about enucleation. Well, movement with enucleation, this is again a retinoblastoma child. Very good movement with the PMMA implant intact there, and that is after the prosthetic eye. Well, there are situations where we land up with complicated enucleations as well. There's a child with an optic nerve glioma who was not treated, unfortunately, initially. There's a large optic nerve glioma sitting in the parents. She is almost blind in the other eye because it's bilateral glioma. The parents were concerned about the cosmesis, and this is a humongous tumor along with the enucleation which was taken care. Since the parents were concerned about the cosmesis, yes, cosmesis rehabilitation was done in this patient. Now, again, certain complicated situation where it's a step-by-step approach in a microphthalmia. Initially, it's a surface expansion with prosthetic eye, customized ocular prosthesis. It's a very microphthalmic eye inside. I got this child in my hand at 2 months of age, and then this is 3.5 years after an enucleation has been done. So I go it in a stepwise manner. Unfortunately, there are situations where we land up with bilateral enucleation as well. Evisceration, contraindication. More than indication, I want to talk about contraindication, which I emphasized. Intraocular tumors and thysis bulbi severe. Ultrasound B scan is a must before you go for an evisceration to know exactly what you're scooping out. A quick surgery on evisceration. There are different techniques. 4-petal is talked a lot about. I don't do it in my practice because I've seen migration of implant in 4 petals if it is not closed well. So I find 2 petals very, very safe. So yeah, this is what I'm going to show you here. This was a painful blind eye in a post-trauma patient. Well, so he had undergone multiple surgeries initially. There is a little bit of scarring in the conjunctiva. Peritomy step is the same. Tenotomy step is the same. Well, you know, we give a stab incision at the limbus, and then the cornea is corneal button is removed. It's the same. It's nothing special here. Well, what I do in order to scoop out the uveal contents, because I want it really neatly, nicely out, I use a periosteal elevator initially to separate the ciliary body where it's really adherent, And then after I make sure that 360 degree the ciliary body adherence is cleared, then only I go out and use the evisceration spoon, because I don't like piecemeal extraction of the uveal tissue. I really love taking the whole thing out. And then, cleaning of it, I cauterize. Then this is the alcohol, absolute alcohol cleaning of the scleral tissue in order to destroy any of the uveal pigments which is residual in the sclera. Make sure the area is dry and the alcohol doesn't spill when you are cleaning with the saline. I almost use 20 ml saline to clean it. And this is the 2 petal. I go in between the 2 recti in different quadrants, opposite quadrants, inferior and superior. I get a nice petal over there where I can put a big implant. This is actually a 20 millimeter implant which it could accommodate. Neatly go inside and then cover the sclera, then the tenons and the conjunctiva. That's a scleral closure, very relaxed closure. That's the conjunctival closure. And
Dr. Kasturi, please
evisceration
sum
is
it up.
easy. Yeah. So this is how he looks after. That's the moment. We're done. Thank you so much. And I acknowledge my ocularist deeply, extremely, who gives a wonderful prosthesis for me after enucleation and evisceration. Thank you.
Thank